Bismillahirrahmanirrahim. So, after atrial flutter, the next topic is ventricular tachycardia. So, let's see a concept behind this. So, you can see here, this is the ventricular myocardium, right? So, we'll have this pathway that is, drawn in the black color. So, we'll have the SA node, AV node, internodal pathways. Then this is bundle of hairs, right? Then we'll have the bundle branches. Then we'll have these small branches. These are called as Purkinje fibers, right? So this is the myocardium represented in blue. So we'll have some ectopic foci that is formed after post MI, right? So it mostly happens post myocardial infarction. There are some ectopic foci which are formed in the ventricle. So they start firing at different rates. Just say they are firing at 200 beats per minute, right? So when ectopic foci they start firing, so there will be conduction. There will be conduction between myocyte, right? They will not use the normal pathway, the normal electrical system, that is Purkinje fibers and the bundle branches. So they will use the myocytes to conduct, right? So there will be intermyocyte conduction, and because of intermyocyte conduction, we'll have the broad complexes, right? So now in this case, you can see the ventricular rate is 200 beats per minute, right? While if you talk about the atria, so they are under control of the SA node. They are firing at 100 beats per minute, right? So in this case, the atrial rate is not equal to ventricular rate, because atrial rate is almost 100 and ventricular rate is twice of that. So we will see when atrial rate is not equal to ventricular rate, we're going to call it as AV dissociation, right? Atrioventricular dissociation. Last time I have talked about atrioventricular dissociation, that is seen with the third degree heart block, right? When there is complete AV nodal dysfunction. So in that case, atria are under control of SA node, and ventricles are under control of the bundle of hairs, right? And because of this atrioventricular dissociation, we'll have the pulseless state, right? So we'll have most of the patients with ventricular tachycardia have the pulse that is absent, so we're going to call it as pulseless VT, right? So that was a little concept behind that. So if we talk about the maximum ventricular rate that is physiologically present, so it is during exercise, it is 200 minus age. And just say if the age is 60, so if we subtract 60 from that, to maximum physiological heart rate in this patient, 60-year-old patient, will be 140 beats per minute, right? That will be under stress, right? So if same patient is having 200 beats per minute, right, heart rate, this means the patient, this is pathological heart rate, right? This was just a bit of exercise for that. So if we talk about definition of ventricular tachycardia, so it is basically a broad complex tachycardia that is firing at 140 to 220 beats per minute and originating from an ectopic focus in the ventricle, right? So it is mostly seen post myocardial infarction, that is most common cause, and we will see the ischemic heart is cause of that, congestive cardiac failure, and cardiomyopathies. So these are the causes of that. So in ECG, we'll see the regular rhythm, right? And there will be broad complexes in these patients, and rate will be almost 140 to 220 beats per minute. So in ECG, we will see some of the signs here. So this is a normal QRS complex, then we'll see the normal QRS complex, then you can see the broad QRS complex, then we'll have the in the deep S wave, we'll have this notch here, right? So let me draw this again here. So we will see in the notch in descending portion of S wave. So this is called as the Josephson sign, right? So this is called as the Josephson sign. The next thing is that can be seen in ventricular tachycardia is another sign, right? So this will be rabbit ear appearance. So in these patients, so we'll see the asymmetrical rabbit ear appearance, right? So if we talk about the bundle branch blocks, so we'll have the symmetrical type of rabbit appearance, rabbit ear appearance, right? So then we can also see the this sinusoidal appearance, right? So this type of pattern is called as sinusoidal pattern. So to diagnose the ventricular tachycardia, if we see that more than 3 premature ventricular beats, right, premature ventricular contraction with heart rate of more than 100 beats per minute, and it should sustain for more than 30 seconds, so we're going to call it as ventricular tachycardia. If any patient is having premature ventricular contractions more than 3 and heart rate is more than 100 and it is present for more than 30 seconds, we're going to call it as ventricular tachycardia. Any broad complex tachycardia, right? Broad complex QRS tachycardia. So mostly we are actually talking about the ventricular tachycardia. So we can see Josephson sign in these patients. We can see asymmetrical rabbit ear appearance in these patients. Also, sometimes what happens that during the runs of ventricular tachycardia, there can be normal QRS complex in between that. So this is called as the capture beat, right? We can also see the sinusoidal appearance, right? And then the last thing is we can see the extreme axis deviation. If we talk about axis in these patients, so I have drawn that, so it will be falling in this direction, right? So this is called as the extreme axis deviation. It is, if it is present in this area, so it will be called as the left axis deviation, right? And this is the normal axis, and if it is present here, so we're going to call it as right axis deviation, right? So the vector will be falling in this area in ventricular tachycardia patients, right? So if we see, there are, we have various types of ventricular tachycardia. That is, one is, monomorphic and polymorphic ventricular tachycardia, right? Then we have sustained ventricular tachycardia and non-sustained. Then we have bidirectional tachycardia, various other types of ventricular tachycardia. So this is the what I have discussed about this thing. This is called as the monomorphic ventricular tachycardia. While there's another condition, so you can see here, this is the monomorphic ventricular tachycardia. If we have broad complexes that are swinging upward and then downward, so this is called as a polymorphic ventricular tachycardia. So polymorphic ventricular tachycardia is also known as the TDP, torsades D point is arrhythmia, right? So mostly we see this type of arrhythmia with electrolyte abnormalities, right? So this can be seen with we can see this with the hypokalemia, hypomagnesemia, and hypocalcemia. So TDP is torsades D point is arrhythmia is seen with those conditions that prolong actually QT interval, right? So when QT interval is prolonged, so it is basically normal QT interval is between 9 to 11 small scales, or it is between 360 to 440 milliseconds, right? So if it is more than that, so mostly we see electrolyte imbalance in these patients, like hypokalemia, hypomagnesemia, and hypocalcemia. So calcium has inverse relation with that of QT interval. If the patient is having tetany, right, so he will be having the QT prolongation, right? So drugs which can cause QT interval prolongation, that includes hydroxychloroquine, erythromycin, right? Then we have cisapride, estimazole, and ketoconazole. So these are not present. These are taken out of from the market because of their problem with the QT interval, right? And we have antiarrhythmic drugs class 1A, 1C, and class 3 antiarrhythmic drugs that can also prolong this and cause the polymorphic ventricular tachycardia. So in this condition, in TDP, we will see the QTC prolongation, right? So QTC is basically corrected QT interval. So that's how it is corrected. If we divide QT divided by RR interval, with under root of RR interval, we're gonna get the QTC interval, right? So treatment of this patient is of polymorphic ventricular tachycardia or torsades D point is arrhythmia is magnesium sulfate, so, right? So we'll have to give magnesium sulfate to this patient. So magnesium sulfate is also given in eclampsia. So these are the other indications of magnesium sulfate. Impending respiratory failure like that of in asthma, right? So acute severe asthma, we're going to give the magnesium sulfate in these patients, right? Also the third indication is torsidy is the point is arrhythmia. So we have to, because hypocalcemia can cause TDP, kalemia can cause TDP, so we'll have to give the calcium gluconate to these patients and give we in usual practice, if any patients are having ventricular tachycardia, so we mostly give magnesium sulfate and calcium gluconate to these patients, because actually we'll have to give those patients who are having the polymorphic ventricular tachycardia. Ideally they should be given the magnesium sulfate and calcium gluconate, right? So if the patient is stable, so we can go for chemical cardioversion, that is injection amiodarone. So this is a broad spectrum antiarrhythmic, right? So we'll have to give the 300 mg IV over 1 hour. So if it gets controlled, then we have to check the cause of that. If it is not controlled, then we can give 900 mg over 24 hours, right? So alternative option is, if we see any post MI patient is having the ventricular tachycardia, so we can give the injection lignocaine to these patients, right? So lignocaine has better efficacy to control the ventricular tachycardia post myocardial infarction. If patient is unstable, if patient is having pulseless VT, or patient is unstable, so we'll straight away go for DC defibrillation, right? We'll have to defibrillate this patient by 200 joules, right? Defibrillation and cardioversion is a bit different. Cardioversion is synchronized, right? Mostly cardioversion is synchronized, while defibrillation means unsynchronized shock, right? So we'll have only two indications for unsynchronized cardioversion or defibrillation, that is the pulseless ventricular tachycardia and ventricular fibrillation, right? So we'll straight away go for the shock, and that's how we're going to terminate the ventricular tachycardia. So that's all for today. That's all for ventricular tachycardia. I'm going to discuss about ventricular fibrillation in next video.